Hello, and welcome to the Health GoLIVE webinar series. Today's episode is brought to you by your friends at Medicision. We would like to remind you that the Q&A feature is available, so feel free to send in your questions for the panel throughout the discussion. And with that, I will turn it over to our moderator, Daniel Gerazio, who joins us from Sage Growth Partners.
Thank you, everyone, for joining us today. There's been a great response to the topic that we're going to discuss, and we have some great panelists here. So we're really excited to dig into this topic. Let me just share my screen here with everyone about when will SDOH get easier. And I could probably substitute different words in for easier. I might be able to say practical. I might be able to say, when will it get easier, when will it get easy, let alone easier? When we'll be able to truly reach patients and members outside of the limited time that we have when we see them, that precious time, which is valuable, but they go off into their own worlds that we typically only know so much about. And I can remember during the pandemic when everyone went to using virtual care, telemedicine, what have you, and providers started to say, I could actually see behind someone and see what their house looked like, right? I could take a glimpse of that environment. And we've always discussed how important it would be to know things like, well, does someone have a tripping hazard in their house, right? Falls are a big problem. Do they actually have food? Food is medicine, has become really strong. In some ways, a return to basics in terms of how we provide care. And I'm thrilled that Dr. Steinberg and Dr. Cantor are here today because you're going to learn about their medical careers and the great skills and capabilities, but you're also going to learn that this is not a science project for them. And what I mean in a positive way is they've been in people's homes. They've seen what it looks like to both treat people, you know, whether it's inside the four walls of a hospital or in a community setting. And we're going to expand the notion of community to actually where people live and work, because so much happens in those environments. So I'm really grateful to Health and Medicision for bringing us together today. And we're going to talk about the importance of tech-enabled interventions. This word tech-enabled is something I think we've all been chasing for a long time. And I was speaking to some folks recently, and they said, you know, in many other industries, we see where tech can make things easier, faster, and cheaper. And healthcare is very unique, and it doesn't always feel that way. And so what I'm excited to talk about today is how technology can be an enabler of SDOH. And while I'm saying SDOH, I could easily be saying health equity, right? And making sure people have what they need to stay healthy. So for a long time, we've been chasing this notion of we have so much process and so much people, how can we use technology? And on the one hand, we've talked about physician networks. Today, we're going to talk about the connection of a physician network with Uber's network, right? And it's a really nice joining and collaboration of how these capabilities are coming together to really make life better for people. I'm grateful to have this opportunity to moderate today with our two great panelists, and Dan Gerazio, with CEO of Sage Growth Partners. And just jumping into the discussion, this data point has become repeatable by many folks. 50 to 80% of individuals' healthcare is affected by social determinants of health. I spent the first 9 years of my career in a community-based setting, working with families in Baltimore. This is going back 25 years, and we would go to the house and we'd go to the kids' schools and we'd try to get them healthcare. And we saw in so many dimensions all the components of their life that were either accelerants or things that were challenging them. 20 years later, I started to hear this word social determinants of health and health equity, and Dr. Steinberg and Dr. Cantor, we talked about this. We didn't know, those words weren't applied years ago to the work that we were all doing in community-based settings. But as it started to come to bear, I think we all realized that work cannot be separated from knowing about people, from getting them the kind of services and capabilities they need, and really knocking down barriers, right? So we hear a lot about access barriers. We're going to talk today about the impact of transportation. We're going to talk about things like food, right? Healthy food. Some of these things are not rocket science, but they're incredibly hard to make actionable. And we're going to talk about the role of technology in making that happen, but also how MedDecision and Uber have partnered to close those gaps, so to speak, right? And it's one thing to make an order. It's another thing to know that it happened, to literally close the loop, to know that a person got the access they need, got to the appointment, got the food that they needed. And in so many ways, technology in healthcare is still challenged by interoperability and data sharing and data silos. And until and unless we make that easier, social determinants of health won't be easier. And that's, I think, the reality that we face today. So as we think about that, I'm really thrilled to have Dr. Steinberg and Dr. Cantor. And I would like for them to share a bit about their background, because I think the texture of their experience really matters in a discussion like today. So Dr. Steinberg, please share a little bit about yourself.
Great. Thanks, Dan, very much. So good morning or afternoon, everyone. I'm Dr. Terry Steinberg. I'm the Chief Medical Officer and the Chief Strategy Officer at MedDecision, which is a health IT company that focuses on care management, social determinants of health, digital engagement with patients and members, and addressing social determinants of health, among other things. I am a geriatrician by training and by practice, and I've worked in the clinical informatics industry and the software industry for more than 30 years. I'm a member of the leadership team at MedDecision, where I help to drive product definition and clinical content, and where I work extensively with our customers and customer prospects. I am particularly excited to be here today, involved in the extension of traditional care management and utilization management into the world of digital engagement and social factors. As Dan said, social factors are very important, something which I have seen firsthand, because as a geriatrician, for many years, I did almost exclusively home visits. And so it's quite remarkable what you can learn about a person simply by entering their home. And I think that this will be a very exciting topic today as we talk about some of the tech advances that really make attending to social factors in healthcare much easier to address.
Thank you, Dr. Steinberg. Dr. Cantor.
Hi there. Thanks, everyone, for joining us this afternoon. It's a pleasure to be with you. I'm Mike Cantor. I'm the Chief Medical Officer for Uber Health. Uber Health is the health-focused division of Uber, the transportation company we're all familiar with. And we're working on some really exciting programs and initiatives to improve access to care through better transportation, to basically integrate opportunities to access needed services and support for people in the community. And we'll talk a lot more about that this afternoon. Technology is a key theme for Uber Health because it's key for Uber. And with the technologies, anyone who's used an Uber knows, we can change the world. We can make it easier for people to just get in the car and go where they want to go, and for other people to see when they're on their way. And we can understand, if we look at the data, where are people going and how often are they going, and learn a lot at a population level, which I think is going to be very useful when we get into our discussion. It'll be very useful for helping to manage populations. I come to this work, like Dr. Steinberg, as a geriatrician for many years. I still make house calls one day a month, and often those house calls are people who are living in challenged environments. They have multiple chronic illnesses. They have behavioral health challenges, substance use disorder. And this is really what today's conversation is about, is understanding that health is not just the absence of disease. Health really is much broader and really has to do with how we are able to live our lives and stay healthy. As a geriatrician, I've worked clinically in that area for many years, and also I've spent a lot of time over the last few years as Chief Medical Officer for health plans, Chief Medical Officer for physician networks, working on improving quality of care and improving efficiency, and working towards the now quintuple aim goals of providing better quality at lower cost better patient experience, better provider experience, and equitable access to care. So really looking forward to the conversation. Appreciate the opportunity to be with you today.
We're so fortunate to have you both. And I want to talk about where we'll head. The first thing is definitions. SDOH is an acronym. We say it. What does it really mean? Sometimes we like to say it's a definition, but without distinction. We want to actually talk about what this means today. How do we know what we're meaning when we say SDOH or health equity, right? Then it becomes a question of how do we access the data that traditionally and still in many parts is not very liquid or transportable, if I could use the pun, right, to get to the folks that need to use it. And by the way, in the workflow, right, we can't separate the reality that, especially in primary care and other specialties, the amount of time providers have with patients continues to shrink, while also we have an access and a coverage issue with the right number of providers. So how do we get it to them in the workflow, in the amount of time they have that matters, right? We talked about how do you track referrals. If we were to ask a health system, when we've done this work before, hey, what is your referral patterns? What is your leakage? How do you measure it? You get a lot of different even definitions about that or views on it. I think the exciting part we're going to talk about today is that we can actually know what happens, right? So if you know what happens, you have a better sense of what the outcome might be or what the expectation can be. And then we have to measure, right? Dr. Steinberg and Dr. Cantor, you're scientists at heart, right? And if we can't measure, and by the way, we can't measure everything, but we can at least measure some of the important components. And that's what's really exciting about the discussion today. So a special thanks again to Health, MedDecision, and Uber. And with that, we've done these great introductions, but I'd like to first say to Dr. Steinberg, tell us a little bit. You've got this great clinical leadership experience. You've also worked in technology organizations. You've sort of seen all sides and facets of this discussion. Tell us a little bit about why MedDecision and what brought you here and why are you excited about what you're enabling?
That's a great question. Thank you for asking. So why is MedDecision here today? Why are we represented in today's discussion? And I think it's really focused on the fact that technology has been a barrier to really addressing the social factors of health. I think that Dan, you talked about the workflow a couple of times. I've long said, whether it be implementing physician order entry or physician documentation or nursing documentation, if you're going to ask people to do something that's outside the workflow, they're not going to do it. And you talked about closing the loop. Well, it's not enough just to request an order or service or a capability. You have to know that it was executed, and you have to know when it was executed and how successfully it was executed. And I was in the provider space for many years, and I came to MedDecision because I profoundly support the direction that MedDecision as a company is moving towards, and that is expanding what was a traditional care management platform into a real-time data platform that can trigger next best actions, that can promote direct communication with patients or members, direct outreach, and can address, I'll call it the soft factors of clinical care, which are the social factors. So whether it's food, therapeutic food, or transportation, or financial components of care, these are all critical, and they have to be delivered within the fundamental workflow. If a physician is using a new technology platform that allows them to address social factors and close the loop and make sure those social factors are successfully addressed and executed, it has to be within its workflow. At MedDecision, And I'll try not to make this sound like a promotional statement, but I'm pretty excited about the work we're doing. We believe that there are no workflows that are simply care management workflows or EMR workflows or pharmacy workflows. The workflows are integrated, and the successful software platforms of the future need to be interoperable. And so an interoperable social determinants of health platform that lets you understand what the issues are by assessing the patient, which we do in the EMR, we do it in care management. You assess it, and then you execute the therapeutics, including social factors, and you can be sure that they were executed. So if somebody needs transportation, you have to be able to deliver the capability to order that transportation right within your workflow and know for sure that that was followed through. If you're making a referral to a food bank, you have to know for sure that the food bank got that referral and did something with it. So that's why I came from the provider side to MedDecision to participate in this exciting new expansion of historic capabilities of care management, as well as to help promote the expansion of care management direct to the member or patient, including, among other capabilities, the ability to address social factors needs.
Yeah, great. And thank you, Dr. Steinberg. Dr. Cantor, I think many or most of us are familiar with Uber. If not, maybe they're from another planet at this point. But why Uber? Why Uber Health? Why this partnership? What has made sense about teaming up here?
So Uber is well known, of course, for being a transportation company, but it also is a food delivery company. It also is a delivery company. Generally speaking, Uber can be seen as a logistics platform powered by technology that can move people or things. So the people could be patients who need to come home after being in the hospital. Uber Health got its start because on Friday afternoons when people were being discharged from hospitals, the hospitals used to give out taxi vouchers. Taxi voucher is very hard to track, very hard to know, did the person actually get home, minor details like that. And so a technology platform like Uber, where you knew exactly where the person was, where they went, you could see that they got home, you could organize it centrally. We have an online web portal that people frequently use, care coordinators use in hospitals and clinics now all over the country to be able to order rides and to make sure that people are actually getting home. For me personally, as a geriatrician and someone who has worked in quality improvement in healthcare for a long time, more generally, the challenge that we face in terms of mobility, just the ability to get people to care or to bring care to the people both ways is significant. And so it's not only the challenges of underserved populations because they're remotely located or they're economically challenged. It's older adults who struggle with being able to continue to drive, whose world begins to shrink once they're unable to drive and they can't get out as much. For many of them, Uber is a fantastic alternative. And when you consider that Uber is not only being able to move people, but also move things, the chance to do things like deliver prescriptions. So people no longer have to worry about, is it coming in the mail or can I get to the pharmacy? But to make sure that that prescription is actually delivered on time and in a timely fashion. As one example of how you can begin to see that this concept of social determinants, which addresses the, in medical school and in residency and fellowship, we talked a lot about the biopsychosocial model of care, and that health is biological factors, diseases, it's also psychological factors, behavioral health issues, but also social, where we live, what we eat, how we move, all of those things come together. Uber, because of its terrific technology platform, and the ease of use and its ubiquity really allows for rapid scaling of solutions for problems of mobility and other related areas that we just have not been able to have before. So the chance to help Uber develop its healthcare focused programs and to work with the team and to work with health plans and health systems and employers around the country to address these issues, which is what we're doing today, was really exciting to me when I joined a year and a half ago. And it's even more exciting now because we're making a lot of progress in developing new products and creating great partnerships like the one we have with MedDecision.
Yeah, you started to talk about that training and the different approaches to how you look at a patient member and their health. can we just try to get to some sort of common denominator, at least for today's call, on when we say SDOH, what does that mean? And let's just be purely practical, right? I like to say we don't need to be a futurist in healthcare. We need to be a pastist and a presentist, because we have problems from the past and problems from the present that we still need to deal with the way our system's grown up. So just today, what does it mean, and what does it come to mean, SDOH?
Well, I can start with that. Before I do, I just want to comment on several things that Dr. Cantor said. I think that the importance of real-time data in a successful workflow in today's world is really critical. That successful platforms will have an awareness of what's going on right now. And that is something that's quite different from the healthcare platforms that we all used in the past. So I think you're going to see that sprinkled through this conversation, how situational awareness for the population that is being managed is really important for a number of reasons. But moving on, when we think about the social determinants of health, we really are thinking about the geographic or economic or situational aspects or social aspects or transportation aspects of a person's life that can have a negative impact if they're not addressed on physical or psychological health. And when we talk about social factors, it's not just the obvious, take poverty, for example. It's not just the obvious insufficient resource, but it's really the insidious impact of an issue with one of the social factors of health. And that might be, in the case of poverty, a mother who is forced to say no to all of her kids' requests. When her kids ask for an unhealthy food choice that the mother can say yes to, she's very likely to go ahead and buy that sugar-sweetened cereal, even though we know that contributes to an unhealthy eating practices. So social factors can be both obvious, not enough money to buy food, or they can be more insidious, which is a poor choice of food purchases simply because of the social situation where mom doesn't want to always say no 100% of the time to her children. So to me, it's both the black and white components as well as the more subtle impacts of having issues with any of the social determinants of health.
I would agree. Just to summarize, it's those things that affect your health that are not directly physical, like medications or testing, things like that, or healthcare interventions or psychological interventions. And so it's food and access to food, it's decent housing, it's transportation or community mobility. If you think about it more broadly, it's also, if you think really broadly, things like education that impact on the health and well-being of the person over their lifespan. So that's how I would define it. A very short list that we can focus on and all agree on, but they're very important. CMS is working towards this as well, and they've selected sort of the transportation and housing and food as sort of the top 3 places to start. But there's a whole world of literature that gets into the details of this. If we just focused on those areas, it could solve the problems related to access to those things. I think people will be a lot healthier.
We've talked about 2 things that I think are incredibly important. The first is, how do we identify folks? And the second thing is, how do we act on it? And we live in the richest, wealthiest, most resourced country in the history of the world, right? And that's the United States. We spend $4 trillion on US healthcare. We have amazing clinicians in medical technology. And then we have fax machines. And we depend on fax machines, which, 40 years ago were novel. And today, there's still fax machine companies in healthcare that frankly are doing very well, because we've got this really stubborn and persistent issue of data liquidity and interoperability. Dr. Steinberg, without having that information, identification is incredibly difficult. I can't imagine that you guys don't deal with that. How do you deal with it? So you've got all this data flowing, and by the way, we're having data increasing at an accelerating rate, right? You think about remote patient monitoring and wearables and all this other data that happens outside of a traditional clinical setting, and then we have the data clinically, and then we've got claims data. How are you bringing that together to first identify? And we've talked about this for a long time, and a lot of people say, yeah, but is it real?
So that's a great question. You know, it is essential to have all the data and to make the data actionable in real time. And when I say all the data, it sounds like you know, pie in the sky, but it actually is possible in today's world with local, regional, and national information exchanges that include a plethora of healthcare data. It is possible to build pipes so that you can pull data that then becomes actionable into your data platform. And that's what we do at MedDecision. That's one of the new things that we have worked on at MedDecision and we are now offering. And for me, it's very exciting because once you have the data, you are then able to have real-time analytics informing human beings of things that they didn't know about before. So take the example of just a simple, you know, ADT, HL7 transaction, where you know when somebody you're managing has hit the emergency department, and you've got an opportunity to pick up the phone and call the ED and give them some information, and maybe they can send the patient home instead of admitting the patient, and you've got the ability to have somebody in their house that afternoon. So having real-time data that surrounds your workflow-based transactional system is essential in the new world. And that includes acting upon social determinants of health, but it also includes having analytics that run, that can execute in one system and can make up can wake up a real-time alert in another system, such as an EMR. So it's really important to have an integrated data system and to build this integrated data system in a way that can alert multiple systems, whether it's Uber's system or the provider's EMR or the food bank system, and then to understand the outcome and to assess the performance. That's what a real-time data platform that surrounds a care management or a social determinant system or an EMR can do. So real-time data is absolutely critical.
Yeah, I often, from all the work we do with our great partners, we've been chasing data, and then we've been chasing analytics, and then we've been chasing insights. And we sort of get to this point where, and one of our clients said this at one point, we need to stop admiring the problem. Like, we're at least at a point where we can look at the data and know we have a problem, but how do we make a change? Dr. Cantor, you guys, as you've described, are a transportation business that can do lots of things. I think it's easy for us to all understand if we had access to transportation, maybe things would be better, but there's a lot of layers there. Can you share what you've learned and what Uber has learned and what Uber is innovating around this notion of transportation, what it means to really get something to someone or someone somewhere? And on the face of it, it might seem simplistic. I'm sure it's not. Nothing in healthcare is that simple. Maybe you guys have figured that out, but please help us, enlighten us a little bit.
Sure. I'd say we're working on it, and we're working on it in partnership with provider organizations and health plans and employers, because all of them play critical roles in the healthcare system, and of course with people, the patients, or even the workers, to help them get to their jobs and to help take care of patients. So what are the challenges we face in transportation within healthcare today? Well, there are a couple of different challenges that I think we're all quite aware of. One is benefit design. So if you have Medicaid, you actually have access to transportation benefits. That's a standard part of the Medicaid program. Although in some states, you cannot access rideshare. So you're not able to access rideshare companies like Uber, even though Medicaid will pay for you to take transportation. So it makes it much harder to have a consistent approach to healthcare, especially I live in Boston. We're pretty close to several other New England states. If I live in New Hampshire, Rhode Island, I'm commuting to Boston for my work and I'm seeing doctors here because that's where I work and spend a lot of my time. I may be challenged in terms of being able to get transportation even across state lines, even though the distance is really short, it's across state lines, and that's a problem for state Medicaid programs. If you have commercial insurance, which is employer-based, you may probably don't have any transportation benefit. Even for people who have chronic illnesses where like dialysis, or they're getting treatment for cancer with chemotherapy or radiation therapy, or they have wound care issues, or they have chronic illnesses like diabetes where frequent visits make sense. Employers have not chosen, this is changing, they have not chosen yet to expand those benefits in a way that could really be optimized and help them help their employees stay healthier and stay at work in some cases. The other thing so for employer-based insurance, the benefit designs are evolving. More and more employers are very interested actually in providing transportation, especially for those key populations. A good example of that, by the way, is maternal health. So providing sort of a bundled solution for if people are expecting babies. So transportation to prenatal visits, food to make sure that the mom is getting healthy nutrition, support for postpartum visits, support for well baby visits, ensuring that there are access to other types of support for breastfeeding. All of those things can be bundled together and made much more efficient. And we're working on now a couple of pilots, actually. We're combining, for example, Uber working with other partners, whether it's federally qualified community health centers or with food as medicine companies, and in some cases both, to create one seamless package for expectant women and for women who deliver and have babies. And so we're really working to create these sort of bundled opportunities to make it simpler for the employee-based plans to be able to offer those kinds of services. And on the Medicare side, we're seeing huge increase in transportation benefits for Medicare Advantage. And so we're providing a lot more rides for older adults who have Medicare Advantage. And we're working to make it seamless so that instead of having to worry about, do you have 12 rides left or 6 rides left, we can now connect to our platform a benefit feed to know who's eligible for the transportation, how many visits, so the care coordinator doesn't have to look it up. They can actually see, like Dr. Steinberg said, in real time within the same platform. Access to data isn't just data about patients, it's also data about what their benefits cover and how much of their benefits have they used this year. So really, we see opportunities, and we're working very closely with health plans, with provider organizations, and with employers to really improve access to transportation and related services when it makes sense, so that we can better treat certain populations of patients as well as the whole population of patients and make sure people get access to the care that they need to stay healthy.
Yeah, that's really helpful. Dr. Steinberg, I'm not sure everyone fully appreciates sort of the history and the origins of MedDecision, and I think as you'll share, it's been born out of a historical payer sort of partnership, but you're moving much more. You've described this UM-CM sort of shift, right? And you're incorporating more data, more clinical insights, more real-time insights, and it requires, I think, all of those components to make this work. Is that a fair
It
comment?
does. It does. And part of the driver for that is that care management is it's changed. It used to be something that was provided by plans basically in isolation. And this is, a number of years ago, but it's slowly evolving into something that is integrated into the care delivery process, and sometimes even delegated to care delivery providers. And so MedDecision has recognized that care management is now, it's an integrated game. And I think, as Dr. Cantor mentioned, care managers, providers, others who assess and act upon social factors needs are busy people. And if you make them go to some other platform to execute, to request a ride or satisfy food insecurity or to address any of the social factors needs, and this is true for both clinical care as well as social factors or behavioral health, if you make somebody leave their foundational workflow and go somewhere else, it won't happen. And so I think previously, addressing social factors, care managers assessed the social needs, no problem with that. But there was no efficient technology platform to then go and close the loop. So yeah, you could go out and you could see a national network of community-based services, but you couldn't be sure that they actually acted upon that order. And now there is a technology that allows you to know for sure, once you've assessed the issue, you've executed the issue. And I believe over time, this will become a mandate, a governmental mandate, to actually not just assess social needs, but act upon them and close the loop. So MedDecision has evolved as care management has evolved. It's evolved from a static, transactional, business-focused, or I should say transactional, business transaction-focused system to one that's informed by data, that has moved from an isolated care management system into an integrated health delivery environment using some of our interoperability tools that we are very serious about, so that everybody can stay in their foundational workflow while still having access to these real-time data feeds and data operations that allow you to do things like close the loop for social factors needs.
Dr. Cantor and Dr. Steinberg, if you want to take a shot at this, there's a couple of really good questions that we're all wrestling with. How do we move beyond pilot mode, right? Like, this all seems interesting. By the way, we're still a lot of fee-for-service. How does this work? Or doesn't it? Let's just be honest. Is fee-for-service really into this, right? You talked about the employer side and the benefit design. And then third, and I'll come back to this, is this all about the doctor having to do this, right? We've talked about care managers. What about people that we're learning? I mean, we're starting to see end-of-life doulas. I never would have imagined, right, that we're there, but hospice, and we have hospice clients. It's amazing. It does wonderful things for the patient and the family, but we're just sort of waking up to somebody. So how do we move out of pilot mode? Is this just a value-based care model? Are there other professionals besides the doctor that has to deal with this? So pilot and fee for service. Dr. Cantor, I'll throw that over to you first. And Dr. Steinberg, I know you have a view on that too.
Sure. So it's time to move beyond pilot mode. And when you look at the millions of rides that we're delivering now through Uber Health, we are moving beyond pilot mode. We're very much a part of the way people access care under certain circumstances in certain organizations, because it's just the better, easier way for people to get to where they need to go and to maintain their health. How is that happening is the question. What are the right conditions? Well, first you have to have the scalable technology. So Uber Health is all over the country. We're in all 50 states and DC and Puerto Rico. So we are in many, many markets, and we have adequate driver supply in many, many of those markets. And we actually measure response times, and we're working with healthcare organizations to show them that we have adequacy in an area. And if we don't, we're very open about that and try to brainstorm other solutions. We're actually beginning to partner with providers of other forms of non-emergency medical transportation, like wheelchair accessible vans or rural health transportation, or ambulance, non-emergency ambulances, because not everyone can get into a car. And so we're working to create a seamless model for non-emergency medical transportation, a one-stop shop. Like Dr. Steinberg was saying a minute ago, if you have to go to 12 different applications to get something, you're not going to do it. So being able to be available at scale across the country for transportation, that's happening now. The benefit designs have evolved and are evolving. So for 2024 on Medicare Advantage, those bids are being put in place now. Basically, the next few weeks, those will be finalized by the government. And in the fall, people will sign up for new MA plans. They're going to look at transportation benefits as being an important part of that. In addition, many MA plans are using what are called flex cards. This is where people get a certain amount of money that they can spend on over-the-counter benefits or other kinds of health-related costs. And in some cases, transportation is part of that. So Uber Health is able to work with health plans that offer flexible benefit cards, and that can be employer-based plans as well as Medicare Advantage, to allow people to directly access those services. So it doesn't have to be the doctor, it doesn't have to be a healthcare provider. The patient or the person themselves can actually access directly those services. We actually did a study in Washington, D.C. With pregnant people with 2 federally qualified community health centers. We identified sort of a transportation desert in DC where it would take an hour by public transportation to get to a community health center. And we provided Uber rides as an alternative. We saw great uptake. 44% of the people offered those rides took advantage of it. By the way, that population is a Medicaid population. All of them had a transportation benefit that existed. Only 8% of them were using it before they were aware of it. And so we made a big difference there. And if you did it, if you elected Uber, you used it 76% of the time for your visits. And we saw an increase in the overall number of prenatal visits by 1 to 2 visits. And so it's a significant improvement in the prenatal care because we provided the benefit in a way that made it easy for people to access. And in some cases, there's a care coordinator who could book the ride, or the pregnant person could choose, do they want someone do they want to get a voucher, a card that they could use to book the rides themselves? And different people had different preferences. And so the more flexibility we build in, the better we're going to be in terms of not just doctors or care coordinators, but family members who are caregivers. We always leave out the caregivers, and they deserve so much more support and recognition. We should make it easier for them because they're the ones in many cases who are actually doing all the work and organizing and coordinating. So we need to offer multiple options, not just a call center. If today you have non-emergency medical transportation, in some states through a broker, you're going to sit on the phone for a long time. You have to book 3 days in advance. Technology like Uber that's flexible, that allows different people access to do it in real time, just makes it easier. And that's how we move beyond pilot, is we have to move away from specially constructed, very specifically chosen populations to address the reality that 3.6 million people a year don't get access to care because they lack transportation. Until we make it sort of available everywhere to everyone under the right circumstances, we're not going to be able to get to where we need to go, but we're working on it. And every day we're making steps and getting closer.
I love what you said earlier, and Dr. Steinberg, I know this relates to your partnership, benefit design, real-time information. If I had to try to figure out what my mother needed in another state and had to figure out a taxi company, or is she eligible, I'd probably spend a couple of days on the phone, right? And so Dr. Steinberg, that information is coming together in a way that is at many people's capability, right? To deploy that now and in the future.
It's, to that point, I think that, if I were to answer the question, what will it take to move us beyond pilot? My answer would be, we now have the technology that anyone can implement. We already assess patients, whether it be as part of care managers' activities or physicians' activities. The providers, the care managers already ask the questions, and now we have the technology that answers the question and can move the needle. It is generally available. It is not rocket science. It is standard. I think what it will take to move beyond a pilot is to be serious about turning this into executable projects that can be successful. And you might start with transportation. You might start with food insecurity. You might start with whatever the social factors need is that one's organization wants to identify. Pick one. Implement the technology that lets anybody in any workflow, whether it be end-of-life workflow or EMR workflow, pick a system that can plug into everybody's foundational system, not just the EMR, not just care management. Pick a Switzerland system that can close the loop on social factors needs, implement it, and measure your outcomes, and then move on to the next social factors need that you want to address. It's easily available technology, and I think that was the barrier. Everyone knew that health equity was important and that addressing social factors needs was important. There was not a good technology that let anybody's workflow address this. And I got into the field of population health when my organization, Christiana Care, where I previously worked, was granted a CMMI, Center for Medicare and Medicaid Innovation Award, to build a technology-enabled, a smart care management system that was data-informed. And we implemented Ariel at MedDecision's care management system. And what we learned very, very quickly was that the most important determinant of outcomes, whether it be cost or admissions or quality of life, were the social factors, the things that nobody really attended to. You could really move the needle on overall well-being and psychological benefits, as well as real clinical care outcomes, simply by addressing social factors. And so, is there a role in fee-for-service? Maybe not yet. But really, is there a role for fee-for-service going forward? That's a big question mark and the topic for another webinar. But certainly, there is enough population health and managed services out there that we can really focus on what's important. And it was the things for which you can't drop a bill, social factors being one of the most important, that determined the overall outcomes. And so it's natural.
Dr. Steinberg, you talked about something very challenging in healthcare. My wife's a clinician, trauma nurse, clinical nurse, nurse manager. Everyone in healthcare joins to make a difference. And you just don't if that's not what you want to do, right? It's the work is too hard, the challenges are too deep, the emotional issues are real. I'm convinced that everyone comes into this and is called to this. No one is just like, oh, I think I'll get a summer job and change bedpans. Like, it's not for everyone. That being said, and I say this with humility, I've never operated in a clinical environment. I've never been an operator. But all my observations for all of our clients and my wife is that healthcare is incredibly difficult operationally. And that I might be smoothing that over. If I were to say it differently, I'd say we're not that good operationally in healthcare. And so you're a care manager and you have all these folks to manage and they've got these benefits and these solutions and you can access it, but how do you know who needs what? How do you figure out when you start your day the person most in need? On your side of the house, how do you make that easier for people? Because is it just the person that calls and is strong enough to advocate for themselves? Is it data that's coming forward? Is it real time? Because if we don't make that better, the people most in need might fall to the back of the line.
Well, I can answer with my experience running a population health risk-based program for about 100,000 lives before I came to MedDecision. And the answer to that is that the old way of doing care management, where you open a program and close a program, doesn't work for chronic disease. And instead, what does work for chronic disease is managing everyone all of the time. Now, nobody's got enough human resources to do that, right? That's just not possible. So the answer to the problem is to build a big data platform, collect data from everywhere you can get it, and have very smart rules that define next best actions, either talk to your members directly using that data. So you can have automated outreach using a platform that, when an event occurs, can send a message to the member without a human being, or you can ping a care manager or a provider when a certain event happens. But the bottom line is that you have to manage your population by surrounding it with data, with a very, very smart and streamlined analytics engine that in real time does the right thing when an event happens. So whether it's a regular assessment and check-in process for people, or it's a piece of data from a lab test has arrived that requires some interaction, or somebody or an event occurs that triggers a care manager, you've got to surround your population programs with a large data platform, and ours is in the cloud, uses all of the modern technology and runs analytics, are always running constantly in real time. Doesn't change what the care managers really do. It changes how they are informed of who is needed. So you might manage your, humans might open care management programs for the riskiest, the highest risk members or patients. But those programs will stay, clinical programs will stay open, and exacerbations will be informed by data points instead of by telephone interactions or the member picking up a phone. It's a different way of working. The systems are now smart enough, scalable enough, and inexpensive enough that they can be deployed to manage populations.
Yeah, so I know a lot of folks showed up on this webinar, many of them are still here. And these are issues we've been talking about for a while. And I could leave this webinar and feel a couple of ways: inspired, intrigued, or how do I make any of this real? Right? Like, what should someone do, Dr. Cantor and Dr. Steinberg? What's the first thing they can think about to make this actionable for themselves or for their organization, so they just don't leave another webinar and go, that was interesting, but, right? And I know there's no solution for everyone. It's not how healthcare works. We're not there yet. But what can someone do? What conversations can they have? How can they engage? And I don't mean calling you 1-800, I'm going to buy your solution tomorrow. Like, it's never that easy. But I don't want people to just leave with, oh, it's interesting, but. What should they be thinking about? What should they be doing? Who should they be talking to?
So I would say that they have to set some priorities. So they need to figure out what is most important to their organization.
Exactly.
And that means doing a little soul searching in terms of what are the biggest issues. A second ago, you asked about fee-for-service versus value-based care. There are a lot of patients who make appointments and then don't show up. That hurts fee-for-service organizations deeply, especially at a time when we're short-staffed and there aren't enough visit slots to begin with. So looking at and understanding when patients don't show up, why aren't they showing up? Maybe it's transportation, maybe it's something else, maybe it's a location, maybe it's a lot of other things. But you have to ask yourself from an organizational perspective, how do I drive the greatest value from my organization? And the way to do that is to offer, in most cases, the greatest value to the patients you're serving. What are their needs? Are they underserved? Are they fine from a financial perspective, but they have challenges with vision or other issues that make it hard for them to drive? Is there a big problem with food in their community and access to healthy food? So really understanding what is that local, very, very local, very organization specific need from a business perspective and from a population perspective. That's first. Once you have those priorities, then you can begin to look at different solutions. And there are a range of solutions for any of these problems. For food as medicine, there are a number of different organizations and companies ranging from Meals on Wheels and local food banks to national food as medicine companies. For transportation, there are organizations like Uber, there are brokers, there are local transportation options as well. For housing, there's a lot that's going on at the local level that involves government, involves non-governmental organizations. But until you understand what's the biggest problem that your organization faces and how are you going to get some early quick wins that are going to show value, you can't really decide where to start. But that's where you start an assessment.
I was just going to do, Dr. Steinberg, one quick follow-up on that. Dr. Cantor, do you see people saying, I'm going to do this for everyone? Do they start with the disease state? Do they start with the community? Do they start with a certain catchment area? I think that's the other thing that could be overwhelming for people, is you can't do it all. How have you seen people sort of roll this out or step into it?
So I've seen all of the above. It really depends on the organization. Generally, they're not starting with boiling the ocean. So pretty much it's where's the biggest problem that I can solve the fastest to get some quick wins as it relates to social determinants of health. As Dr. Steinberg said earlier, data are so important. You need to know, if you're running a dialysis program, for example, where people have to show up 3 times a week, Why are people not showing up? Are it correlated with certain neighborhoods, with certain times of day? What's going on that we can address, and how can we address it? Maybe a transportation issue, maybe something totally different, but you don't know until you actually look at the data and understand.
Love it. Dr. Steinberg, I know you've seen this on every side, and especially now at MedDecision. Where do people start? What should they do?
I echo what Dr. Cantor said. You don't wait for the perfect technology platform, although that makes life a lot easier. You start by what makes sense, whether it's a particular condition like pregnant women, making sure that they get to their prenatal care, or you start with a population, one of your lines of business. It doesn't matter where you start. You have to have you define the business process and you figure out the workflow, and then you figure out how you're going to execute the workflow. Very often people start backwards. They start with the, they'll pick a technology, or they'll try to shoehorn what they're trying to do. They'll define their business process by what their existing EMR can do. It doesn't work that way. You have to figure out how you want to deliver care, how you want to address the social factors. And then you look at your own very local conditions. What are your networks? What are your providers? Who are your payers? What are your needs? And pick something. It doesn't matter what you pick. The second one will go better than the first one. But you have to start with something, and you have to start with a very defined business process and learn from that.
I love what you said. The second one will be better than the first. I heard someone once say, we're not talking about pilots, we're talking about phases. Phase one means there's a phase two. It's a certain level of commitment. We only have probably 90 seconds left. How has virtual care accelerated or changed this whole notion of social determinants for Uber or MedDecision? In many ways, we can reach people we haven't, but maybe that means there's more of a need for this than we even realized. And just like a closing thought, because our models are becoming hybrid more than they ever have prior to the pandemic.
So, I think virtual care has made it's changed roles. So, in virtual care, you have people they may be visiting an urgent care center or a telemedicine provider, not necessarily going back to their same primary care physician. They're basically going wherever it's easiest. It's all about reducing friction. And so from my perspective, I believe that the care manager is the glue between the visit, the only person who actually sees everything. And so plugging these big data systems into virtual care and providing the capability to act upon the needs becomes so much more important in a virtual environment.
Love it. Dr. Cantor, you have 10 seconds for that answer. How about it?
Sure. So virtual care means you see people who have sore throats and need a swab. They need to be picked up and taken somewhere if they're too sick or don't have access to transportation. So it actually can enhance and make it easier for people to get the rides that they need to get to care on an urgent basis. And for chronic care, the same thing.
Thank you. You guys were amazing experts. This is a rich conversation. We'll be back because we certainly haven't solved this, but we really appreciate what you've done to increase our knowledge. And by the way, you've given us more than hope this is happening. Remember, phase one, not pilots. Thank you everyone for joining us today, and we look forward to having you again.
Thank you to MedDecision and to everyone that joined us today. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, October 8th through 11th for Health 2023.